Welcome to Pediatric Case Review. Today we present a comprehensive case-based review of medium-chain acyl-coenzyme dehydrogenase deficiency, one of the most common and most important fatty acid oxidation disorders in pediatrics. This condition can be fatal if unrecognized, yet with early detection through newborn screening and simple fasting avoidance, outcomes are excellent. We will walk through 12 carefully crafted clinical cases covering clinical triggers, biochemical hallmarks, physical examination findings, genetics, newborn screening, confirmatory testing, differential diagnosis, dietary management, acute illness protocols, complications, prognosis, and perioperative care. Let us begin. Case 1. A 14-month-old boy is brought to the emergency room with 2 days of poor feeding and vomiting following a viral upper respiratory illness. He is now lethargic and difficult to arouse. Blood glucose is 1.8 millimoles per liter. Urine ketones are absent. What is the primary metabolic trigger for this acute decompensation? Option A, high dietary fat intake causing lipid overload. Option B, excess protein catabolism for muscle breakdown. Option C, prolonged fasting depleting glycogen stores during illness. Option D, mitochondrial toxicity from viral replication. The correct answer is option C, prolonged fasting depleting glycogen stores during illness. In medium-chain acyl-coenzyme dehydrogenase deficiency, fasting is the critical trigger. When a child becomes ill with vomiting or poor intake, glycogen stores deplete rapidly. The body then shifts to fat oxidation for energy, but the deficient enzyme cannot process medium-chain fatty acids with 6 to 12 carbon chains. Without fat oxidation, no ketone bodies are produced, and the brain loses its backup fuel source. The result is hypoketotic hypoglycemia, which progresses from lethargy to seizures to coma. This is a medical emergency. The key ages at risk are 2 to 24 months, when illness combined with fasting most commonly triggers a crisis. Case 2. An 8-month-old boy is brought to the emergency department after a 12-hour fast during a viral illness. He is lethargic and difficult to arouse. Blood glucose is 1.8 millimoles per liter. Urine ketones are negative. Liver is palpable 3 centimeters below the costal margin. What is the most characteristic metabolic finding in this condition? Option A, elevated urinary ketones with normal glucose. Option B, metabolic alkalosis with hyperammonemia. Option C, hypoketotic hypoglycemia with elevated acylcarnitines. Option D, lactic acidosis with elevated pyruvate. The correct answer is option C, hypoketotic hypoglycemia with elevated acylcarnitines. This is the biochemical hallmark of medium-chain acyl-coenzyme dehydrogenase deficiency. When glucose falls during fasting, fat mobilization is triggered and free fatty acids are released from adipose tissue. Medium-chain fatty acids enter the mitochondria via the carnitine shuttle, but the deficient enzyme blocks their oxidation. Acyl-coenzyme A species with 6 to 12 carbon chains accumulate, and the acylcarnitine octanoyl carnitine, known as C8, rises dramatically. Critically, ketogenesis fails because medium-chain fat oxidation cannot produce acetyl-coenzyme A for ketone body synthesis. The brain has no backup fuel. In normal fasting, glucose is low but ketones are high. In this deficiency, both glucose and ketones are low, which is the paradox. Case 3. A 10-month-old boy is brought to the emergency room after 18 hours of poor feeding and vomiting following a viral illness. He is lethargic and difficult to arouse. Blood glucose is 1.8 millimoles per liter. Ketones are absent. Which physical examination finding is most expected in this infant during an acute medium-chain acyl-coenzyme dehydrogenase deficiency metabolic crisis? Option A, generalized lymphadenopathy and splenomegaly. Option B, hepatomegaly with hypotonia and depressed consciousness. Option C, peripheral edema and distended neck veins. Option D, petechial rash and bulging fontanelle. The correct answer is option B, hepatomegaly with hypotonia and depressed consciousness. During a metabolic crisis, 2 organs are primarily affected, the liver and the brain. Hepatomegaly develops because impaired fatty acid oxidation causes lipid accumulation in hepatocytes, leading to fatty infiltration of the liver. Cerebral edema signs include hypotonia, lethargy, abnormal eye movements, which can progress to seizures and coma. These findings reflect systemic energy failure during the crisis. Fasting depletes glycogen. The enzyme block prevents fat oxidation, no ketones are produced, and organ damage follows. Elevated liver transaminases are also commonly seen. The combination of hepatomegaly and encephalopathy in a young child with hypoglycemia and absent ketones should immediately raise suspicion for a fatty acid oxidation disorder. Case 4. A 3-week-old male infant is identified on newborn screening with elevated C8 acyl-carnitine. Confirmatory testing confirms medium-chain acyl coenzyme a dehydrogenase deficiency. His parents are unaffected and are first-time parents with no known family history of metabolic disease. They asked the geneticist what is the genetic cause of their child's condition. Which gene mutation and inheritance pattern is responsible for this deficiency? Option A, phenylalanine hydroxylase gene mutation, autosomal recessive. Option B, hydroxyacyl coenzyme a dehydrogenase alpha gene mutation, X-linked recessive. Option C, acyl coenzyme a dehydrogenase medium chain gene mutation, autosomal recessive. Option D, electron transfer flavoprotein dehydrogenase gene mutation, autosomal dominant. The correct answer is option C, acyl coenzyme a dehydrogenase medium chain gene mutation with autosomal recessive inheritance. The gene is called ACADM and it is located on chromosome 1p31. Mutations in this gene produce a dysfunctional enzyme that cannot oxidize medium-chain fatty acids with 6 to 12 carbon chains. The most common mutation is C.985A greater than G, also known as P.lysine 329 glutamic acid, found in approximately 90% of symptomatic cases. Because the condition is autosomal recessive, both alleles must be affected for disease expression. Carriers with one mutant allele are clinically unaffected. The genotype-phenotype correlation table shows that homozygous C.985A greater than G has less than 2.5% residual enzyme activity and more severe clinical presentation, while compound heterozygous patients may have milder disease. Case 5. A 6-day-old male infant born at term via uncomplicated delivery has routine newborn screening results received. The metabolic panel shows a significantly elevated value in one specific acyl-carnitine species, flagged as abnormal by the screening laboratory. The infant is currently asymptomatic and feeding well. The C8 to C2 ratio is elevated and the C8 to C10 ratio is elevated. Glucose is normal. Which acyl-carnitine species is the primary diagnostic marker for medium-chain acyl coenzyme dehydrogenase deficiency on a newborn screening report? Option A, propionyl carnitine, known as C3. Option B, palmitoyl carnitine, known as C16. Option C, octanoyl carnitine, known as C8. Option D, isovalyryl carnitine, known as C5. The correct answer is option C, octanoyl carnitine, known as C8. C8 acyl-carnitine is the primary diagnostic marker for medium-chain acyl coenzyme a dehydrogenase deficiency. It is elevated in the dried blood spot on newborn screening because it accumulates when the enzyme is non-functional. The acyl-carnitine profile in this deficiency shows C8 as the dominant elevation, with C6 hexanoyl carnitine and C10 decanol carnitine also elevated, but to a lesser degree. The C8 to C2 ratio and C8 to C10 ratio are used to further confirm the diagnosis and increase diagnostic specificity. A C8 value greater than 0.5 micromoles per liter triggers confirmatory workup. Option A, propionyl carnitine C3, is elevated in propionic acidemia. Option B, palmitoyl carnitine C16, is associated with long-chain fatty acid oxidation defects. Option D, isovalyryl carnitine C5, is elevated in isovaleric acidemia. Case 6. A 3-day-old newborn is flagged by the State Health Department following routine newborn screening. The infant appears completely well on examination. The parents asked the pediatrician how did the test detect a possible metabolic problem from just a few drops of blood, which technology is used in standard newborn screening programs to detect fatty acid oxidation disorders such as medium-chain acyl coenzyme dehydrogenase deficiency. Option A, fluorescent immunoassay of whole blood proteins. Option B, tandem mass spectrometry of dried blood spots. Option C, enzymatic activity assay of red blood cell lysate. Option D, urine organic acid chromatography. The correct answer is option B, tandem mass spectrometry of dried blood spots. This technology analyzes dried blood spots collected from a heel prick performed on day 2 to 3 of life as part of routine newborn screening. Tandem mass spectrometry detects elevated C8-octanoyl carnitine, which is the primary marker for medium-chain acyl coenzyme dehydrogenase deficiency. The process begins with the dried blood spot sample, followed by methanol extraction, then analysis through the first mass spectrometer, a collision cell, and the third mass spectrometer to generate the acyl carnitine profile. A C8 value above 0.5 micromoles per liter triggers confirmatory workup. The C8 to C2 and C8 to C10 ratios also increase diagnostic specificity. This screening method has revolutionized early detection of fatty acid oxidation disorders and is the single most impactful intervention for preventing metabolic crises. Case 7. A 5-day-old male infant is flagged on routine newborn screening with an elevated octanoyl carnitine, C8, level of 1.8 micromoles per liter, where the reference is less than 0.5 micromoles per liter. He is currently asymptomatic, feeding well, and has no family history of metabolic disorders. His repeat dried blood spot confirms the elevation. What is the most appropriate next step to definitively confirm the diagnosis? Option A, repeat newborn screening dried blood spot in 2 weeks. Option B, start empirical dietary fat restriction immediately. Option C, plasma acyl carnitine profile plus urine organic acids plus ACADM molecular genetic testing. Option D, liver biopsy to assess fatty infiltration. The correct answer is option C, plasma acyl carnitine profile plus urine organic acids plus ACADM molecular genetic testing. The diagnostic pathway proceeds in steps. Step 1 is the newborn screen showing elevated C8 on dried blood spot via tandem mass spectrometry. Step 2 is plasma acyl carnitines confirming elevated C8, C6, and C10 with elevated C8 to C2 and C8 to C10 ratios. Step 3 is molecular genetic testing of the ACADM gene to identify pathogenic variants and confirm the diagnosis definitively. Urine organic acids provide supportive evidence showing hexanoylysine, subaroglycine, and dicarboxylic acids, which are characteristic of this deficiency. An important clinical tip: always send plasma acyl carnitines during a metabolic crisis because levels may normalize between episodes. Enzyme activity assay in fibroblasts or lymphocytes is optional and useful only in ambiguous cases. Case 8. A 4-year-old boy presents with 2 days of vomiting and confusion following a viral upper respiratory illness. He was given aspirin at home for fever. Labs show alanine aminotransferase 310 units per liter, aspartate aminotransferase 280 units per liter, ammonia 95 micromoles per liter, which is elevated, blood glucose 2.8 millimoles per liter, and urine ketones trace. Acyl carnitine profile is pending. Which feature most helps differentiate medium-chain acyl coenzyme dehydrogenase deficiency from Reye syndrome in this child? Option A, elevated liver transaminases. Option B, markedly elevated ammonia with normal acyl carnitine profile. Option C, elevated C8 acyl carnitine with inappropriately low ketones. Option D, hypoglycemia with high urine ketone levels. The correct answer is option C, elevated C8 acyl carnitine with inappropriately low ketones. This is the key differentiator between medium-chain acyl coenzyme dehydrogenase deficiency and Reye syndrome, as both can present with encephalopathy, liver dysfunction, and hypoglycemia after a viral illness. The deficiency typically presents at 2 to 24 months of age, often before the first birthday, and is triggered by prolonged fasting or intercurrent illness with no aspirin association. Reye syndrome affects school-age children, typically 4 to 12 years, and is linked to viral illness, especially influenza or varicella combined with aspirin ingestion. Biochemically, the deficiency shows elevated C8 acyl carnitine, hypoketotic hypoglycemia, and hexanoylysine in urine with absent ketones. Reye's syndrome shows markedly elevated ammonia, elevated liver transaminases, and a normal acyl-carnitine profile. A normal acyl-carnitine profile rules out the deficiency. Case 9. A 6-month-old male infant was recently diagnosed with medium-chain acyl coenzyme dehydrogenase deficiency following an abnormal newborn screen. His parents ask how long can he safely go without feeding overnight. Option A, up to 4 hours between feeds. Option B, up to 8 hours between feeds. Option C, up to 6 hours between feeds. Option D, up to 12 hours between feeds. The correct answer is option C, up to 6 hours between feeds. Maximum safe fasting durations vary by age, and this is critical knowledge for managing medium-chain acyl coenzyme dehydrogenase deficiency. For newborns to 4 months, never fast more than 4 hours, day or night, with no exceptions. For growing infants 5 to 6 months old, the limit is 5 to 6 hours, adding roughly 1 hour per month of age. So at 6 months, the maximum is 6 hours. For infants 7 to 9 months, 7 to 9 hours. For infants 10 to 12 months, 10 to 12 hours. For children over 1 year, the maximum is 12 hours, and no overnight fasting without an uncooked cornstarch snack at bedtime. During illness at any age, fasting limits are halved and oral glucose should be started immediately, escalating to intravenous dextrose if needed. Case 10. A 14-month-old boy with known medium-chain acyl coenzyme dehydrogenase deficiency presents to the emergency department after 18 hours of vomiting and poor oral intake following a febrile illness. He is lethargic, pale, and unable to tolerate any oral fluids. Blood glucose is 2.1 millimoles per liter. He has no intravenous access yet. What is the most appropriate immediate intervention? Option A, oral glucose gel applied to the buccal mucosa and discharge home. Option B, subcutaneous glucagon injection and observation for 2 hours. Option C, intravenous 10% dextrose infusion at 1.5 times maintenance rate. Target glucose above 5 millimoles per liter. Option D, nasogastric tube insertion with dilute fruit juice administration. The correct answer is option C, intravenous 10% dextrose at 1.5 times maintenance rate. This child cannot tolerate oral intake, so hospital admission with intravenous glucose is essential. The trigger for emergency intervention is fever above 38.5 degrees Celsius, vomiting, or poor oral intake. The goal is to maintain blood glucose above 5 millimoles per liter at all times, with an intravenous rate delivering 10 to 12 milligrams of glucose per kilogram per minute. A critical safety point: glucagon is ineffective and contraindicated in medium-chain acyl coenzyme dehydrogenase deficiency because glycogen stores are already depleted during a metabolic crisis. Glucagon cannot raise blood glucose when there is no glycogen to release. If the child can tolerate oral intake, offer glucose tablets or sweetened drinks first. Do not delay, as catabolism begins within hours. Every family should carry an emergency letter and medical alert bracelet at all times. Case 11. A 7-year-old boy was diagnosed with medium-chain acyl coenzyme dehydrogenase deficiency through newborn screening at birth. He has been managed with strict fasting avoidance and an emergency glucose protocol. His parents ask about his long-term cognitive development compared to children who were diagnosed only after their first symptomatic metabolic crisis. Which of the following best describes the impact of early newborn screening on long-term cognitive outcomes in this deficiency? Option A, newborn screening has no significant effect on cognitive outcomes because neurological damage occurs prenatally. Option B, children identified through newborn screening have higher rates of moderate to severe intellectual disability than symptomatic cases. Option C, early newborn screening identification dramatically reduces cognitive impairment, with near elimination of moderate to severe intellectual disability. Option D, cognitive outcomes depend solely on the specific gene genotype, regardless of screening timing. The correct answer is option C. Early newborn screening identification dramatically reduces cognitive impairment. Newborn screening changes everything for medium-chain acyl coenzyme dehydrogenase deficiency. It prevents brain injury because metabolic crises cause irreversible neurological damage, and screening stops them before they ever start. It triggers early treatment so that fasting avoidance begins before the first crisis occurs. The outcome data is striking. Before newborn screening was available, 67% of affected children had cognitive impairment. After newborn screening implementation, only 11% had cognitive impairment, representing an 83% reduction. Even more dramatic, moderate to severe intellectual disability was 13% in the pre-screening era and 0% in the post-screening era, a complete elimination. Newborn screening is the single most impactful intervention for this condition. Case 12. A 3-year-old boy with known medium-chain acyl coenzyme dehydrogenase deficiency is scheduled for elective inguinal hernia repair under general anesthesia. He is otherwise healthy and well-controlled on dietary management. His last metabolic crisis was 18 months ago. What is the most important perioperative consideration for this patient? Option A. Administer prophylactic antibiotics 24 hours before surgery. Option B. Restrict all oral intake for 12 hours before surgery per standard NIL per OS guidelines without modification. Option C. Initiate intravenous dextrose infusion before surgery and maintain until adequate oral intake resumes postoperatively. Option D. Supplement with medium-chain triglyceride oil the morning of surgery to boost energy reserves. The correct answer is Option C. Initiate intravenous dextrose infusion before surgery and maintain until adequate oral intake resumes postoperatively. Surgery requires enforced fasting, which is the single greatest danger for patients with this deficiency. Never fast a patient with this condition without intravenous glucose coverage. The perioperative protocol involves starting intravenous 10% dextrose at 1.5 times maintenance rate the evening before surgery. During the operation, blood glucose must be monitored with a target above 5 millimoles per liter, which is above 90 milligrams per deciliter. Postoperatively, continue intravenous glucose until the child is tolerating oral feeds. The anesthesia team must be informed of the diagnosis in advance, and the emergency letter must accompany the patient to the operating theater. Option D is wrong because medium-chain triglyceride oil is contraindicated as these patients cannot oxidize medium-chain fats. Before we wrap up, here is a quick note about our Pediatric Case review community on Patreon. In our community, you will find all videos systematically arranged by body system for easy navigation, so you can access every lecture in one place. All presentations used in the videos are also available as downloadable high-quality images, perfect for offline review and practice of all questions. If you are interested in details and how to subscribe, simply comment below in this post, and we will message you directly. New lectures are added regularly, so you never miss a case. Here are the 6 key clinical takeaways for medium-chain acyl coenzyme dehydrogenase deficiency. Number 1. Newborn screening saves lives. Tandem mass spectrometry detects elevated C8 acylcarnitine early, before symptoms appear. Number 2. Never fast. Strict fasting avoidance is the cornerstone of daily management. Number 3. Glucose is life-saving. 10% dextrose intravenously at 1.5 times maintenance during illness or metabolic stress. Number 4. Protect the brain. Each metabolic crisis increases the risk of cognitive impairment and developmental delay. Number 5. Emergency letter always. Every family needs a written emergency protocol and medical alert identification. Number 6. Watch for obesity. Frequent feeding prevents crises but can cause excess weight gain, so monitor carefully. Thank you for joining this Pediatric Case review lecture on medium-chain acyl coenzyme dehydrogenase deficiency. We hope this comprehensive case-based review has provided valuable clinical insights into recognition, diagnosis, and management of this important fatty acid oxidation disorder. These lectures are for educational purposes only and do not constitute medical advice. Always consult current guidelines and specialists for clinical decisions. Please follow our channel for more case-based pediatric lectures. If you have any questions or topics you would like us to cover, comment below and we will be happy to hear from you. See you in the next lecture.